Mayors, good morning to you. Thank you so much. I'm looking around this room and everyone looks almost wide awake. Somebody told me that we took 4 buses down to the quarter and only 2 came back last night, so I don't know. Y'all need to know that cameras in the French Quarter, you know. Just saying. Anyway, it's nice to see all of you. Thank you so much. I hope that you had fun in our city. I think the opening plenary that we had yesterday and the panels last night were incredibly instructive. I'm sorry I wasn't able to stay with you the whole night, but all of you, I know, are aware that we're in the middle of some work that we're doing in the city right now on an issue that actually we've been talking a lot about with this infrastructure, our water system, our energy supply, and the need to have massive investments so that we can protect our energy and water and our drainage systems in America. And I know that we're going to talk a lot more about that, and that our conference has done a lot of work on it. So I look forward to working with you. Because of the situation that we're in this city, I'm going to ask Mayor Benjamin to handle the panel on opioid addiction, which we're going to have right after this with Mayor Whaley and others, and then I'll be back as my time allows. But I want to just tell you how much I appreciate the effort that y'all have all undertaken to be here. I know that you have a lot of things going on in your city. I know that mayors are hands-on and on the ground, and I know it's hard for you to be here, but I think it's important for us to continue to find common ground, to be able to amplify our message, to be able to be impactful not only on the federal level, but to share best practices on the local level so that we can deliver for our constituents. So I thank you for that. Also, I want to, of course, thank Tom and the entire staff of the U.S. Conference of Mayors, and of course, my staff that has been working with them. Sarah Robinson, Sarah, stand up so everybody can see you, has been working hand in hand with the staff of the U.S. Conference of Mayors, along with Scott Shallett, and they've worked really hard. So please just thank all the staff members for the work that they have done. A couple of announcements. First, about the technology. You have microphones in front of you when you speak. The way this system works, if you push the button and it goes on, obviously it'll amplify your voice. But if after you finish you don't turn it off, somebody else is really not going to be able to talk. So after you finish, if you would turn your mic off, that would be helpful. And if you don't want to turn your mic off and stop talking, please honor the chair and do it when time is called so we can stay on time. So I thank you with that. But now look, just like at our winter and annual meetings, we're using the mobile app this morning. If you don't already have the app, you can download it on the App Store or Google Play. The app has the latest up-to-date agenda, the list of meeting attendees, and other hopeful issues for you. If you have any issues with getting the app or logging in, please see David Burns. David, where are you? David is gonna help you with that. Also, you know that we can't do a lot of our work without our sponsors. And as we begin, I want to acknowledge one of our co-chairs of our Business Council Steering Committee, Amy Curran, with CGI Communications. Amy, thank you so much for joining us. Now, I also want to take the opportunity, thank you. You can give her a round of applause. Thank you, Amy. I want to take this opportunity to thank our sponsors, the American Heart Association, Calcasieu, CH2M, Comcast, Denton's, Focus Merchant Services, HMS Host, Lindberger, Goggin, Blair, and Sampson, Loud, Halier, Mobility, Napoli, Shalnick, PLLC, Nationwide, the Orpheum, Plexus Group, Reynolds American Inc., Strata, and Suez. So if we could just give our sponsors a round of applause, I'd appreciate it. And now I'm going to call on Reynolds American Inc.'s Mike Brown to provide a few remarks. Michael, thank you for being with us.
Absolutely. Thank you so much, Mr. Mayor. It does my heart well to be in front of the members of the U.S. Conference of Mayors. I spent a lot of time in front of you all in my past capacity with the U.S. Department of Housing and Urban Development as a political appointee. So I've met a lot of you all in the past when I did intergovernmental relations, and now I'm at Reynolds American, a subsidiary of British American Tobacco. So, you know, I just want to thank you all for your commitment to the communities that you serve and the people that you represent. I want to thank you so much for your steadfast leadership in tackling the real issues that directly impact the communities that you serve, such as affordable housing, aging infrastructure, public safety, community and law enforcement relations, economic development, job creation, to also include support for small businesses and neighborhood markets, as well as the opioid epidemic, in which you all will be talking about a little later on today. It's because of your vision, strategic thinking, and determination that our communities are places in which people want to live, eat, work, and play. So once again, thank you so much for all that you do. We look forward to being partners with you all and with the U.S. Conference of Mayors, and enjoy the beautiful city of New Orleans. I know I did last night, and luckily I'm here this morning with a couple cups of coffee.
Michael, thank you.
Absolutely.
As a conference, as many of you know, we have been very busy, so I want to thank all of you for our participation in our annual meeting. And of course, the meeting in Miami Beach, which I trust all of you share my view, was just spectacular. We had a great turnout, over 250 mayors. We had a full agenda of several distinguished speakers, including President Clinton, Secretaries Alexander Acosta, David Shokin from the VA. Mayor Bloomberg came and talked to us. And to our newly elected membership of mayors, I want to welcome you all here. To our seasoned leadership, thank you for your ongoing support and all the work that you've done. I want to talk just a minute about the progress that we've made since our annual meeting. In Miami, we launched Leadership in Action, the mayor's agenda for the future. It outlines the top priorities that all of us have worked to identify and to focus on, and of course, you know the list well. Our first priority is always public safety. Our second is infrastructure, and I can tell you a big story about the immediate impact that issue is having on the city of New Orleans as we speak. Economic growth and workforce development, and of course we spoke a lot last night about the issue of equity and income inequality and the things that plague the difficulty of making sure that we have to go forward together or we can't go forward at all. Now, since that meeting, I can tell you, Tom and his team and all of our teams have been working overtime. We continue to push to prevent cuts to CDBG and other key programs, as well as the elimination of state and local tax deductions. On health care, I can tell you, mayors, I know you were listening to Governor McAuliffe last night talking about the impact of governors, and they had an impact, but guess who else did? The mayors of America did, in a really big way. In partnership with them, in partnership with NACO and the NLLC, we did a good job of being impactful around a critical issue, and it was because of the tremendous amount of work that our team did and the work that you did in your particular areas to be present, especially in the states where a lot of senators were forced to give some serious thought to the decision that they were about to make. Now, of course, that issue is not over. We have to stay engaged in it, but the bigger point is that when we came together, we made a difference, and I hope we still do that. Just last week, I was part of a delegation of mayors that went to the Hill. We focused on our top priorities. We talked about infrastructure, health care, tax reform with the Senate and with the national media. And of course, now we're here. And so when we were putting the agenda together, I heard from everybody that you wanted more meat on the bone. So we really packed the agenda last night, today, and tomorrow with a lot of information about substantive issues that are real to us every day. And so the discussions are going to inform our strategy discussion that we are going to have tomorrow. So hopefully throughout the day you'll be listening with a keen ear, because tomorrow when we meet with mayors only and we walk through these particular issues, we're going to want to develop clear direction from you about what the conference can do in a full-throated way. So if you can listen today with those kind of ears, that would be helpful. We have gathered a group of really terrific experts that are on the ground in America that can communicate to us the impact that policies in Washington have, or the inability of Washington to deliver to the streets, and they're going to talk about that today. But today is not about stating our problems, but gathering ideas and building new partnerships. So I really look forward to a full day of discussions. I know that you won't be quiet. I want to encourage aggressive discussion. I would just encourage us to be soft on each other, but really hard on the problems, and I think that will hold us in good stead. But with that, I want to introduce the leadership that you know well and ask them to speak. Of course, Steve Benjamin has been doing an incredible job for us. Our second Vice President, Brian Barnett of Rochester Hills, and of course, Tom Cochran, our leader. So I want to open it up to those guys for a couple of comments, and then we'll move on to the next agenda item. Mayor Benjamin.
Thank you, Mr. President. Thank you for this incredible leadership. You are a model example of the great leadership that mayors provide every single day. Guys, we play offense and defense at the very same time, and we work to deal with some of the long-term challenges our various communities face while we're also focused very intently on the future. And I thank you for this bold and aggressive agenda that you brought to the U.S. Conference of Mayors and brought us, our leadership here. We look forward over the next, not just a couple of days, but over the next year to continuing this incredible pace of activity and excitement that Mayor Landrieu brought to the table. And just want to encourage all of you that as we continue to plan for this next year, that you will see very little, if any, daylight and continuity as we go into next year. We're on top of and on the vanguard, and I dare say the tip of the spear on so many important issues right now at a time when I believe the citizens of not just America but the world need us to be. So thank you for being here. Looking forward to some active and open discussion right now. God bless you.
Thank you. Mayor Barnett.
Thank you, President Landrieu. Good morning, everyone. It's a privilege to be here and to be a part of this organization. I want to thank President Landrieu for having the vision to bring together such incredible groups like the U.S. Conference of Mayors, NACO, NLC, the Warthogs, Hells Angels, and everyone else you brought together to participate.
Those are my guys, so don't, it's my security detail.
Looking forward to the discussion. President Landrieu has set forth, I think, an aggressive and robust agenda, not just for this particular meeting, but for the next year. And I think we are at our best when we're working together and when we're focused. In my 11 years with this organization, some of the proudest moments that I've been a part of have been these leadership meetings, these specific focused visits to the Hill. Last week when, as President Landrieu mentioned, several of us were on the Hill, there was certainly recognition of the voice of mayors. We underscored important victories like CDBG, and we put a renewed focus on items like marketplace fairness and tax reform. And I think that's where we all have certainly some value that we can bring to the table to benefit not only your personal community, but this organization and America as well. So President Landrieu, Vice President Benjamin, looking forward to this discussion and appreciate the opportunity to be here this week.
Thank you, Mayor. Tom Cochran.
Hey. Thank you, Mayor. I will wait and talk tomorrow, mainly about issues that we've been dealing with. But here's what I'd like to say. Recall what was said last night and listen and learn today, because tomorrow we got to come out of here with some plans to do big things. There are several issues before this nation that awaits a plan for the mayors of the United States, health care, infrastructure, et cetera. So Mayor Landrieu has done a great job. We've worked to bring the best last night and today. And so get off of your iPads and your iPhones and listen. Excuse me. It's because tomorrow we got to get to work and come out of here. We are not a think tank, we are a do tank. So we have to decide not what the problem is, but what in the hell are we going to do about it. So I look forward to learning today and listening and working with you tomorrow to come forth with a plan for our nation. Thank you very much.
Tom, thank you so much. I'm going to step out in just a minute. Mayor Benjamin is going to lead this panel on opioid addiction, but I wanted to just say a couple things. First of all, Marty Walsh couldn't be with us today, but he's been helping lead this effort in this conference with Mayor Whaley, and I know a number of you. This has become a issue of catastrophic proportions for our country. More people are now dying from opioid overdoses than people who are getting shot on the streets of our city, and we know that that is a catastrophic problem, or suicide, or other issues. The numbers are not trending in the right direction, they're trending in the wrong direction, so it is going to be incumbent on all of us to really understand this better, get a handle on it, and as Tom said, to come up with an action plan that I pray will include a partnership with the federal government and the state governments, because it's going to be all hands on deck for us. we have an estimated 142 people dying every day from a drug overdose. If you run those numbers up, 50 to 60,000 Americans a year, of course, over 10 years, that's 600,000. And I think that's really not the end of it. I think that sounds like the beginning of it, because all of us are beginning to see the tremendous challenges. Research shows that Americans consume more opioids than any other folks in any other country. In New Orleans, we saw 211 all-drug overdose deaths in 2016. Opioids were involved in over 75% of them. And like you, we are doing everything we can to combat this problem. We're trying, and we've expanded access to naloxone. We're increasing access to treatment, and we're working to limit prescription abuse. There are a lot of other things that we can do that I think we're just scratching the surface on, and I know that we have to get to it sooner rather than later. So with that, I am going to turn it over to Mayor Benjamin for the panel that you're going to have, and excuse myself, and then I will be back as my time permits, hopefully in a couple hours. I'll see you soon. Thank you, Mayor Benjamin.
Thank you, Mayor Landrieu. During today's session, we're going to explore a few of the tools currently available to us as mayors as we seek to address this major public health crisis. We had a chance to chat a little bit about the opioid epidemic last night, and I know each of us has our own other very personal stories, and certainly compelling stories affecting each of the communities that we represent. In South Carolina alone, the year before last, we had 5 million prescriptions written in a population of just 4.96 million. We watched, of course, opioid overdoses exceed deaths, exceed homicides for the very first time. OD is up 57% year over year. Major challenges, and we're so happy to have these not only thinkers but doers, as Tom says, and here in our panel. First, we have Nan Whaley. She's the mayor of Dayton, Ohio, and has been a national leader in responding to the massive crisis of opioid addiction. Dayton was one of the first cities in the U.S. to pioneer the use of Narcan, the overdose reversal drug. Nan has also led the way in holding Big Pharma responsible for their role in creating this epidemic, recently announcing that the city of Dayton will sue these companies. We also have with us Josh Sharfstein, a physician, Associate Dean for Public Health Practice and Training at Johns Hopkins Bloomberg School of Public Health. Josh has served as Principal Deputy Commissioner of the U.S. Food and Drug Administration, as Commissioner of Health for Baltimore City, and as Health Policy Advisor for Congressman Henry A. Waxman. Josh will talk with us about evidence-based treatment and prevention options, as well as innovative approaches that communities are exploring to address substance abuse disorders locally. As we know, a key tool in the fight to keep overdose victims alive is naloxone. We have with us Mike Potestio, Director of Sales for the U.S. for Adapt Pharma, the makers of Narcan. Mike's going to walk us through the use of Narcan and how your city can purchase Narcan at a discounted rate through our U.S. Communities Cooperative Purchasing Agreement. We highlighted some of that at our summer meeting. Finally, we have Joyce Linehan, Chief of Policy for Boston Mayor Marty Walsh. In this role, she advises the mayor on a wide array of issues, from housing to economic mobility, to workforce development, to substance use disorder. Joyce and Marty's team has developed a mayor's toolkit on opioid prevention and treatment. You should have a copy of it in front of each of you by now. We're looking forward to discussing the toolkit and all these other incredible resources. We're going to hear more from Joyce on its content and usage. We're going to hear brief presentations from each of our panelists in the order in which I introduced them, and then open the floor for mayoral discussion. So, Mayor Willie, you're up.
Thanks, Mayor Benjamin. And, you know, I never thought that the excitement would be talking about substance abuse at 8:15 in the morning in New Orleans, but, you know, a lot of times these issues come our way. And leadership, I think, is having to deal with what's in your community. I just want to make a couple of comments to talk a little bit about the issue of accidental overdose in the state of Ohio. We do lead the nation, unfortunately, in accidental overdose deaths in the state. I heard Mayor Benjamin and others a couple of times saying that accidental overdose or opioid overdose deaths have exceeded homicides. In 2014, across the country, they actually exceeded car accidents. More people are accidentally overdying of accidental overdose deaths than they are of car accidents in our country. In our county, for example, we have around 48 homicides every year. Last year, we had 342 people die of accidental overdose. In June of this year, we exceeded that number already. One thing you need to remember is you'll see it on the ground first in your community, because the CDC numbers usually lag around 2 years. So the numbers that they're talking about nationally are 2 years behind what's happening in your community. Talking to your public health folks to see what's exactly going on month by month during this epidemic is key. We declared a state of emergency in the city of Dayton in the first quarter of 2014, particularly to deal with harm reduction, to do needle exchanges across our community so we could really reach out to those addicted. And I think for us, I mean, back in 2016, we actually started calling it a natural disaster. Like, we should treat this like the natural disaster it is. You know, the cost and the threat to compassion fatigue for your first responders and police is coming. You know, most of them will say, look, I didn't take on this job to provide Narcan every single hour of the day, but frankly, that's what has become in a lot of communities across the state of Ohio and country. So I just wanted to make a couple of comments about, I think, the opportunities and the need for leadership in communities around this. First of all, I think when we did the summer meeting and had the conversation in Mayor Walsh's Substance Abuse Committee room, what I think is very obvious is we went around the room with mayors, and every mayor pretty much had a personal story about overdose. It was either about somebody that worked for them, someone in their family, a neighbor, a community leader. And I think what that really shows is that this is touching everyone, and this is probably the first time that we've had an addiction issue that has touched every part of our community. So as mayors, I think we have both an opportunity and a responsibility then to really galvanize the community around this issue to get addiction policy right. Frankly, we've been, as a society, been dealing with addiction in a jurisprudence way rather than a treatment way. And we need to recognize that with this epidemic, there are two things that are going to happen. Number one, it's going to be incredibly expensive. For someone to be treated for opioid addiction, it'll take around 5 years. So just keep that in mind, because some people think that this can be fixed in 30 days. That's a fallacy, and you're setting people up to die when you think that. And secondly, because this epidemic does not discriminate, that it affects every single class, every single gender, every single community in your city and across the country now, that gives us the opportunity to really have a system for dealing with addiction in a very meaningful way. And it's a need really in communities to have mayors lead on it. We're the only people that can really get every single group in our community together to call meetings, to really make sure that we can touch every single piece of this issue, because you need your whole community to do it. Finally, we did last June, we're the first city in Ohio to sue drug companies, distributors, and some doctors for the issue. Frankly, how this started in the Ohio River Valley in Wisconsin and West Virginia and through our community was, you know, this started when in the 90s, pain was given as a vital sign by the FDA. And, you know, I believe, you know, we're a manufacturing community and a manufacturing state, and our people use their backs and use their bodies. And when they went to their doctor and said, man, I have a lot of back pain or my leg hurts, the doctor said, oh, well, try this pill. It's not addictive, because these folks pushing it told doctors that it wasn't addictive. The said person says, oh, this isn't, this will help me feel better. It did, go back to work. And the next thing you know, they're addicted to opioids. So around 2011 and 2012, we had a lot of people in Ohio addicted to opioids, and the state, the Attorney General, we've got to close these pill mills, these pills, which is completely appropriate because people were addicted. We said even then, well, that's fine, but as soon as you close that, people are still addicted. And so they moved to heroin, and now this latest surge that we're seeing in accidental overdose death is because of fentanyl and carfentanil that's now even laced with marijuana in our community. So we have decided that, the expense for this, the 40% increase in mutual aid for first responders, we don't even have enough ambulances to save people's lives in the city of Dayton. The $370,000 we've already spent just this year on naloxone, the work that our police officers and first responders have to do on the ground, the hollowing out of neighborhoods over this addiction, that those that started this mess should clean it up. And so we have sued the drug companies, the drug manufacturers, and some of the doctors that marketed this on a lie. The city of Lorain and the city of Parma, Ohio have also joined. There's about 8 counties in the state of Ohio. I've sent some of the complaint to you all as well. Steve Williams of Huntington, West Virginia has also been a terrific leader on this issue, again, because we have to. And I look forward to the conversation that we get to have moving forward. Thanks for having me here today, Mayor Benjamin.
Thank you for your leadership, Mayor Whaley. Dr. Sharfstein.
Thank you so much. Thank you so much for having me. I'm Josh Sharfstein at Johns Hopkins. I worked as the health commissioner in the city of Baltimore for Mayor O'Malley and Mayor Dixon. And I'm so honored to be speaking to mayors. I totally appreciate the what can we do spirit. I went from the city level to the federal government level, and I kind of acted like a city official when I started in the administration. And at a certain point, I got called in, and people said, "There's a serious problem with your behavior in the federal government." And I said, "What is that?" And they said, "We like the fact that you bring us problems, but we don't like the fact that you always try to bring us solutions." It's unfortunately a true story. So I am here to talk about the opioid epidemic and different kinds of solutions. I have tremendous respect for Mayor Whaley and the work she's done and what so many mayors are trying to do. And I think I have just a couple slides. I was asked to really focus on what specifically can cities do. And at the school now, we work with cities, counties, and states to try to put into place the most effective, measurable strategies around the opioid epidemic. And I'll just say that the center of all this is data and leadership. Leadership will come naturally to you. Data is very important and sometimes hard to find at the city level, but really understanding what's going on in your city is really important. And you can often get direct reports from the medical examiner's office or from hospitals that will really tell you what's going on. Let's see if this may not be working. Oh. Here we go. So I'm going to give you 4 things that you may not have thought of in quite this way. The first thing is at the city level to focus the medical community, your medical community, both on appropriate and reduced prescribing of opioids for pain, and many people don't think about this yet, on how they can be part of the solution for people with addiction. And I'll give you a couple examples there. There's a study that if people start addiction treatment in the emergency department, the chance that they're successful, as opposed to just giving them a referral, goes from about 35% to 75%. It over doubles. It was a randomized trial published in a leading medical journal, but very few hospitals actually are willing to start the treatment in the emergency department. And you could bring together your hospitals and emergency departments and ask whether they're really part of the solution for addiction in that way. In Rhode Island, the health commissioner has set the standard for hospitals to do that. And that is starting to spread in different places, but it can have an enormous impact. The second thing is, it's not, I think, enough just to say we want more treatment. I think at a city level, you can actually design and develop a treatment system so that you can follow someone from when they need help all the way to where they get it. And When I was in Baltimore, we did that for opioids. We had an 80% decline in heroin overdoses, deaths, 80, from 1999 to 2010, and it was coincident, this is this graph here, with our expansion and access to treatment. And we got that in part because we had at the city level, you could call 311, you would go to your first place. We had people got induced into medication-assisted treatment. They got case managers. They got referred to long-term, a place they could get longer-term treatment. And we did this at a scale of thousands of patients and had a tremendous impact. So I think there's more you can do with your medical community than you might have thought of, and particularly with the hospitals, to get them to be part of the solution and not just less of a part of the problem. The second thing I would talk about is law enforcement, and here there's been tremendous innovation at the city level, and here what you want to do is do more of the good stuff and less of the stuff that law enforcement could do that could actually make the problem worse. So what are the things that can really help? Certainly Narcan, making sure that law enforcement carries Narcan, but I would also add in their coordination with law enforcement around disrupting the supply, if you can, of fentanyl, because that is responsible for majority of overdose deaths now. Highly, highly potent adulterant in heroin, for example, and cocaine. And to the extent that the supply can be disrupted outside your city, that will be very important. But in addition, police officers now are doing more pretrial diversion. Fire stations, police stations are turning into places that people can go and seek help and then get referred into treatment. And also, trying to get the people who are cycling through the criminal justice system and try to grab them and get them into treatment. Treatment is what really saves lives and reduces the number of overdose deaths. And in order to get people into treatment, you have to find them when they need help. And a lot of those people are actually cycling around the lockup and police departments. I will just mention that there are some things that I think, and I think that may be dangerous, that law enforcement can do. If you're trying to criminalize every overdose scene, that can be very difficult. People will stop calling 911, and also you may wind up just charging people who are basically addicted and sick because they do a little bit of selling, and in the end, that just will drive everything further underground. Many places require people to withdraw when they get arrested. Say someone is addicted to heroin, they get arrested, they go into florid withdrawal behind bars, they come out, and they're at extremely high risk of overdose and death. And so getting treatment into the jail system is really important, and Providence is doing that now. It's a very effective way to reduce recidivism and reduce the chance people will come back. The third thing I would say, and I thought that the report from Boston here, it does a great job on this, is mayors can be incredible leaders in the language that they use about addiction. And this may seem just like a semantic thing, but it really isn't. Many people think of addiction as a moral failure, a law enforcement problem, something we just want to get people out of here. But in fact, it is a brain disease, it is a chronic illness, and with appropriate support, people can do very well. If somebody is in effective treatment, the chance that they will do well in the long term is on the ballpark of 60 to 70%. Opioid addiction is one of the most treatable addictions, and the people who have opioid addiction come from all walks of life and get into trouble for all sorts of reasons, and sending the message that we want to help people get into life-saving treatment is incredibly important and helps people themselves seek treatment at the right time. Finally, the last thing I'd say is that cities have a very important opportunity to promote innovation in the response. And when I was a health commissioner in Baltimore, our overdose rates for heroin were down to like 70 in the city, and now they're in the hundreds again. And the reason that they're in the hundreds again is fentanyl and very, very cheap heroin, but fentanyl particularly. We didn't have fentanyl when I was health commissioner in Baltimore. You all are facing a fentanyl epidemic, extremely potent. How do we respond in a different way to something that is new and different is a question that's important. And even though I would say the things that I've talked about, getting the hospitals, getting the police, are all going to help, we're still dealing with something new, and nobody has really figured out what to do around fentanyl that will really knock out the deaths. And that requires some innovation. Some of the things people are thinking about are interim treatment, getting people into treatment through mobile units, getting people into treatment in the syringe exchange. Because people don't know whether this deadly fentanyl is in their drugs, we are studying, and different places are thinking about doing field testing and allowing drug users to bring their drugs to see whether fentanyl's in there, giving them an opportunity to get into treatment at the same time. And then you even have discussion of safe consumption facilities where people could go and use drugs safely and have an opportunity to get into treatment. I visited one of these places in Europe, and you go in, there are 25 staff who work there. They help people get into housing, they get them medicines, they basically support them, and while they may be using for a little while, they really move on into treatment and do great. And you know, city in Barcelona, for example, has I think twice the number of people as Baltimore, and like 1/20th or 1/40th the number of overdose deaths. They just treat it very differently, and the opportunity to think about innovation with evaluation is something that mayors can really lead on. So I'll conclude there and just say that the Bloomberg American Health Initiative, which I am leading now, is going to be continue to work with cities and counties around the country. We offer full scholarships to people for studying this issue in public health school. They can do it remotely from your city government. If you have any interest, you could just Google the Bloomberg American Health Initiative or follow up through the U.S. Conference of Mayors. For me, they're full scholarships that can be done either on site or remotely in the area of addiction and overdose. We'd love to have people from your cities participate. Thank you.
Thank you, Dr. Sharfstein. Mr. Potestia.
Thank you. My name's Mike Potestio. I'm the Executive Director of Field Operations for Adapt Pharma. We're the manufacturers of Narcan nasal spray. I had the privilege to speak with some of you earlier in Miami about a month and a half ago, so bear with me if you've seen these slides. I'll try to be brief. So a few facts about opioid overdose. Overdoses claimed about 33,000 lives in America in 2015. 15,000 people died involving prescription opioids, so that's about 42 deaths per day. Most of these deaths happen in people's homes, away from medical care, and there were 260 million opioid scripts are written in America every year. According to Dr. Volkoff at NIDA, this is a public health epidemic with devastating consequences. And what's of note is in 2015, there were just about 13,000 deaths related to heroin, but over 22,000 deaths related to prescription opioids. And as you can see here, the red states showed a statistically significant rate of increase from 2014 to 2015. All 50 states and the District of Columbia have passed naloxone access laws for layperson use, and 40 states also have layperson use of naloxone along with Good Samaritan laws. So they've made a lot of progress at the state level in the last couple of years to get naloxone out into the hands of people who need it. So let's talk about Narcan nasal spray. Narcan nasal spray is the first and only FDA-approved nasal form of naloxone. It's indicated for the treatment of an opioid emergency, such as an overdose or a possible opioid overdose with signs of breathing problems and severe sleepiness or not being able to respond. It works in the brain to temporarily reverse the effects of an opioid overdose until medical help arrives. Again, Narcan nasal spray is the first and only FDA-approved nasal form of naloxone. It's available as a ready-to-use needle-free 4 milligram concentrated dose in one single spray. Narcan nasal spray is not a substitute for emergency medical care. You should always call and get emergency medical help right away. Please visit www.narcan.com or go to the App Store and download Narcan Now for full prescribing information and how to use video. Here's our important safety information. I'll give you a few seconds to peruse that. I didn't think you'd want me to read it to you.
Thank you.
Yeah. I guess it doesn't want me to advance.
It's a very long slide.
Oh, there we go. So Narcan nasal spray requires no specialized training. If you encounter a person experiencing an overdose, Narcan nasal spray comes in a box with 2 devices, each blister packed. All you do is peel back the blister, gently place the tip of this device into the nose, and actuate. Wait 2 to 3 minutes. If you don't see a response, give the second dose. And of course, as always, call 911 immediately. And as mentioned earlier, Adapt Pharma has partnered with US Communities to provide Narcan nasal spray to you all at a discounted rate. We sell 1 box of Narcan nasal spray for $75, which includes 2 devices, so it's $37.50 per dose. And that price is for all government agencies, first responders, community-based organizations. Our wholesale acquisition cost is $125 for 2 devices. Of note, we were approved in November of 2015. We launched with this price structure, and we have never taken a price increase. We've partnered with US Communities and their Purchasing Alliance Premier Inc. to provide this to all the communities across America. Thank you.
Thank you, Mike. Thank you so much. And now, Joyce.
Good morning. Sorry. Very, very happy to be here. I want to thank Mayor Landrieu and Mayor Benjamin and Mayor Whaley for their leadership on this issue. It feels like there's very fertile ground here for cities to work together, no matter what comes in the way of support from our states or from the federal government, so thank you for that. Mayor Walsh is very sorry that he couldn't be here today, but knows that you all understand. I wanted to present a toolkit that our team in Boston put together with the help of a lot of cities in this room to address the opioid crisis. In 2015, Mayor Walsh created the Mayor's Office of Recovery Services, which we think is the first municipal office in the U.S. that is solely dedicated to addressing substance use and addiction issues. This was a fulfillment of a campaign promise that he made in 2013. ORS utilizes highly localized collaborative approach to actively address substance use and addiction in Boston's neighborhoods. We found that with a lot of issues that cities deal with, it was really a matter of coordinating a lot of efforts that were already happening on the ground and trying to initiate some real systems change and trying to deal with the crisis. So we work across all of the city departments. We build partnerships with state and federal partners, as well as local service providers and the recovery community to coordinate an accessible citywide recovery strategy. So the toolkit, which you all have a copy of in front of you, Actions to Address Substance Use Disorders in American Cities, is meant to provide some ideas for mayors and for policymakers in dealing with the municipal issue. It provides resources, recommendations, policies, and program solutions to help you and mayors across the country respond to the effects of substance misuse in their communities. It's available on the City of Boston's website. We're also happy to make it available to be hosted on any of your websites if that's of interest. It includes a lot of information from other cities, so I think that that would be appropriate. And rather than walk through the whole toolkit, I'm going to focus on 5 policies that cities can use, ranging from cost-neutral initiatives to some initiatives that might be a little bit more involved. So what can mayors do? As Dr. Sharfstein noted earlier, language is important. Words really matter. And on pages 9 and 10 of the toolkit, you'll find that we made some suggestions about words that you might consider using when talking about the issue of substance use disorder. Some of the terms that we use sometimes perpetuate some bias and some stereotypes that don't really reflect the current medical terminology. Mayors are in a really good position to work on this, and it's cost neutral. What we do is we try to make sure that every speech that the mayor gives, all of the talking points that he's ever given that deal with this issue, that we're being very, very intentional about using language that adheres more to current medical terminology. Studies have shown that stigma often prevents people with substance use disorders from entering treatment, and language can affect the care that the patients receive. For example, clinicians are less likely to refer to patients described as substance abusers to treatment compared to patients described as people with substance use disorders. So just be really intentional as you're talking, as you're designing speeches, and that will go a long way to helping with the stigma issue. In Boston, we also implemented, and I think a lot of other cities do this as well, a 24-hour 311 for recovery services. We started this in September of 2016. Our 311 service now connects callers with an organization called PATHS, which is our Access to Care program. It's available to individuals and to families, and we're seeing an average of 110 calls per week. That's a slide from PATHS. That's the organization that we're referring people to. We also have a lot of providers on the ground in Boston, and it was really important for us to foster partnerships with both people who are dealing with this issue and people who are in a position to deal with this issue. So the types of partnerships that you would want to explore would include public safety and first responders. In Boston, we're doing a lot of this. Our police, fire, and EMS distribute resources, and they collaborate on street strategies and overdose response and coordinate data. Our firefighters actually go back and knock on the doors of the families where they've dealt with an overdose and try to figure out if they can get the person's family to agree to get the person to treatment if that has been attempted at the emergency room and didn't work. And all first responders in Boston do carry naloxone. We've partnered with the Suffolk County Sheriff's Department to create a recovery reentry panel within the South Bay Correctional Facility, where in the weeks preceding release, incarcerated individuals attend an information panel on addiction recovery and support, workforce programs, educational opportunities, housing assistance, and faith communities. Mayors can also work to expand access to naloxone, and Mike talked about this quite a bit. There are a couple of different things that governments can do to follow to increase the access to naloxone. Under the third-party model, the third-party prescription law, doctors are allowed to provide naloxone to anyone who's related to, or friends with, or associates with anyone likely to overdose on opioids. And this allows doctors to put naloxone in the hands of people who are most likely to make a 911 call in the event of an overdose situation. And under the standing prescription model, pharmacies apply for standing prescriptions given by the State Department of Public Health to administer naloxone to anyone who seeks it. Finally, this isn't in the toolkit because we just opened it last week, but some municipalities are experimenting with engagement locations. So in Boston, we have a situation where we lost the site of a lot of our treatment programs a few years ago when a bridge to the island where these programs were sited went down, and we had to relocate a bunch of programs. It caused a lot of the folks who are dealing with addiction issues to come to one particular part of the city, which was causing a lot of pressure from neighborhood associations to get us to try to do something about the fact that there were a lot of people hanging out on the street, openly using and causing a lot of anxiety for the neighborhood folks. So we opened an engagement center. It's a pilot program. It's in collaboration with our Bureau of Recovery Services, the Boston Police Department, and a lot of other City Hall departments. The center offers access to recovery, housing, and city services, clean bathroom facilities, water, coffee, some light snacks, quiet space, reading materials and workstations, and it's shaded and air conditioned. Currently, it's open from 7 a.m. to 7 p.m. daily, which is part of the time that the shelter system isn't available to people. So we, as I said, just opened it last week, and this is what it looks like. And we are hoping that by engaging some of the folks that are hanging out on what some people in our city call Methadone Mile, but we like to call Recovery Road, we hope that we can get people engaged and into treatment using the engagement center. So those are some of the points that are in the toolkit. We are happy, our team is happy to work with you as you're thinking about new strategies to deal with the epidemic. And we would like to keep adding to the toolkit. So I would ask that if you have things that aren't already in here that you want us to add to the toolkit, that you send them to Crystal or be in contact with our office in Boston, and we'll all work on this together. Thank you.
Thank you, Joyce. Now, Mayors, we're going to have a little bit of time for us to talk. I'm going to open up the floor for discussion and questions for our panelists. And so the first question comes from Mayor Richard Berry.
Good morning.
I'm going to try to introduce everyone, but if I fail to, please make sure folks know who you are and which city you're from as well.
Sure. Richard Berry, Albuquerque, New Mexico. New Mexico traditionally has had an opioid issue. We had, for a long time, a county in northern New Mexico, when I was a state legislator, we studied this, that had the highest per capita overdose rate in the country, Rio Arriba County. So we're very familiar with this. Interestingly enough, we used to be the per capita leader in overdoses, and now I think we're 8th. And it's not because we're getting better. And so this really is an issue. Here's a question, just kind of an overall question for our experts that are here. So what I saw in the legislature, of course, it has, I've been mayor now 8 years, and it's changed dramatically, especially with fentanyl and some of the other, the advent of some of these other things. So a lot of what we're talking about today is how to save somebody's life, with the idea that if we can save their life, I'm guessing we can then work over time to direct them to treatment. I heard 5 years, I heard expensive, but I also heard 68% success rate, 60% success rate. So could one of our experts kind of give us an overall picture of how this relates to other epidemics? You know, we've had other drugs over time that have permeated in the country. Opioids back in the 60s and 70s, then it went away. It was other things. It was cocaine, it was crack, it was et cetera. How does this relate to the overall picture of what are we going to do in the long game on this thing? So we're going to save lives with naloxone, and then we're going to try to direct them to treatment. Who's going to pay for the treatment? Do you think it's state, federal? Is it going to have to be cities? And then what does it look like 5 years down the road if we do it right?
Sure. Thank you. It's a terrific question. I think the biggest thing that's new in the last few years, so let's go back maybe to, say, the year 2000, where what started then was the huge surge in prescribing of prescription opioids, and that's what's leading some cities to take legal action, understandably, but it went up fourfold. And so you had a surge in deaths from OxyContin and other prescription opioids, and that really started to peak around 2010. In 2010, heroin really began to take off compared to prescription opioids. Since 2010, the prescribing of prescription opioids has sort of plateaued and even started to fall. Heroin came in Maryland, for example, where we have very good data. We saw, an increase in prescription opioid deaths in 2010 as heroin was at an all-time low, basically, or since, for many years. But then very cheap heroin, very plentiful, started to really surge, and people, as there was starting to be a crackdown on prescription opioids, started to switch over. And if you've read Dreamland, you read about how that happened a little bit. So from 2010 to now, we've had a substantial amount of heroin on the opioid side coming in, and it's been just shooting up in some places like Maryland, 100% increase year over year. Starting in November 2013, and we can almost put a point on it because we have very good data from the coroner's office, the medical examiner's office, fentanyl began to enter the supply. There had been a previous, a few years before, 1,000 people in the United States died from fentanyl, and then the one lab that was making fentanyl was shut down, and that just went away. In Maryland, we went from 1 or 2 fentanyl deaths a month, and that was diverted fentanyl from the hospital, 1 or 2 a month, to now we're at over 100 a month in Maryland. And that is because it's not diverted from the hospital. There are labs in other countries, we think predominantly China, that are making fentanyl and these analogs of fentanyl like carfentanil and furofentanil that are cheaper than heroin, and people are lacing into it. It's essentially impossible to modulate. It's so potent. The teeniest little bit can kill someone. So if so when people don't know, it's like playing Russian roulette every time. And so this huge surge in overdoses that we're seeing now is being driven by the fentanyl on top of the heroin that started in 2010. So I'm just trying to give a little bit of the historical sweep of this. To your question about treatment, when people are in the throes of addiction and they can enter treatment, it can take a little bit of time for them to really be only on treatment and not using illicit drugs. But often, for many people, it can happen quite quickly, and a very good program, for example, that uses medicines like Suboxone or Methadone can get people on a much better path very quickly. It's not 5 years of drug use for the vast majority of patients. They, very quickly, within days to weeks, they can be able to start putting the pieces of their lives back together. There is such a stigma associated with those therapies, and in part that is because some of the treatment programs haven't been high quality, but if you find and you can support the quality of treatment programs, people very quickly can do well in large numbers. That's how we got an 80% decline. And it does mean that people will be in treatment for a while and in recovery for a while because it's a chronic illness. But for other chronic illnesses like diabetes, we say it's okay to be on insulin for a while. It is totally fine to be on methadone or Suboxone for long periods of time if you're doing well. One of the most important things is to measure success by the overdose rate, whether crime is down, and when people get treated, crime is down. There are very good studies from Baltimore and elsewhere, whether their families are intact, whether they're employed, all of those things. And I'll just end by saying that my wife is an addiction medicine physician. I'm a pediatrician. And when we were in medical school and she started going towards addiction medicine and I started going toward pediatrics, I thought, that I would be getting presents from my patients, and just being the great pediatrician, and my wife, it was such a hard job she would have. Well, it turns out parents are pretty busy and they don't give a lot of presents to pediatricians, and the kids are doing well anyway. But my wife takes people from the absolute brink of death. They are on the street, they are often selling themselves. It's just the worst situation. And when they do well, and the vast majority of our patients do well, they have their families back, they're contributing, they're working. It is an incredible transformation. It's like oncology, taking someone from the brink of death from cancer. And I would encourage all of you, if you haven't visited a good treatment program in your city, to get out there and meet them and see what happens, meet people who are in treatment, and really be able to talk about it at that level, because that can be really helpful for people to go in and seek treatment. And I do think you can see, and it wasn't just Baltimore that had an 80% decline. In Paris, they had an 80% decline. Places that have really focused on getting people access to highly effective treatment, they see just huge improvements in all kinds of indices, not just overdoses, but crime and employment and other things.
I was going to say, I think the doctor's right. I think we have to think of this very differently than how we've been thinking about it. And I think that's frankly, the opportunity we have as leaders to change our thinking on it when it comes to addiction. Just like with medical-assisted treatment, right? We used to think of addiction if you're not completely off all drugs, then you're not treated. Now we recognize that folks are going to be on MAT for a very long time, and how that's funded is really important to our community. That's why I think when we had the discussion on healthcare and Medicaid, the issue of addiction services was such a big part of it. Such a big part, because if folks don't have access to this, some of this treatment is very expensive every day. The other thing is, a lot of us are in larger cities. I'm surrounded by a lot of rural community areas, and they don't have much medically assisted treatment. So, making sure that there's access for it across your state is really important, so folks aren't having to drive 45 minutes, an hour every single day. Getting those systems in place is really key. And we're talking with folks that are very enlightened here. We talk on the ground. I have a weekly conversation with neighborhoods where they, a fight with the neighborhood folk yeah, this is a choice, this is a moral failing. We have every single day have to change how people think about this if we're really going to make a difference. And so I think that's the long play on it. If we do this right and deal with addiction in a way that treats it like the disorder and disease it is, we can make our communities and our states and country much more strong. I think that's the opportunity we have here. You know, we have some levers with the criminal justice system and with parents and families to do that. But we have to make sure that we're really serious about getting the whole system around and recognizing that it is going to be a long term. It's not a fix it and done kind of problem. And I think that was the hardest part for me, Mayor, was, you know, okay, my first responders are going to have naloxone, we're going to, you know, save lives, but you have to have the whole system if you're really going to move it. And I think that's the frustration on this. The one other thing, too, I'd say on crime, we did a study in Dayton in 2014 and 2015. 90% of our property crimes were done by someone who was addicted. So this has just such an effect in our communities as well that we have to make sure that we try to get it right.
Sure.
Mr. Benjamin?
Mayor Rawlings and Mayor Buttigieg.
Thank you. Just a quick question. This is an issue for all America, but some geographies are, it's a crisis, another, it's creeping. Has anybody studied about why it's in certain areas and why it's not as intense in other areas? And is there some forecast of this moving in this area faster than other areas?
And it's Mayor Rawlings from Dallas.
That's a very good question. And I don't have a full answer. I would say places that had historic heroin problems have been hit especially hard by fentanyl because it's just come right in through that. And then places where there were just huge expansions in access to in opioid prescribing, including Ohio, for example, has been very, very vulnerable. And there's also different patterns of where heroin flows in the United States that have had an impact. So I would certainly say every place should be very concerned about this coming, but there are some questions that have no really clear answers. In Baltimore, for example, we were always preparing for methamphetamine and it never really arrived. So, you know, some places have certain kinds of drug cultures or challenges, and it doesn't really shift. So, but I would say that particularly if there's heroin and prescription opioid prescribing, you're very, very vulnerable, and getting a good sense of what's actually happening rapidly from your medical examiner. If you're not getting that, I would strongly encourage that. Sometimes people can really be behind by a year or more if they're not plugged into what's actually happening.
And I would say, too, in the 1960s, 80% of folks that were addicted to opioids started with heroin and moved to prescription drugs. And today, that's the exact opposite. So places that had just enormous prescription drugs, these, you know, numbers of opioids, you know, more than one prescriber per person in a state, like you're going to see this. And then the fentanyl being moved, I mean, it's being moved through the mail now, you know, so it can just come right into a community in just a couple of grains. And, you know, we've had issues in Ohio where, you know, it gets on our first responders and then 3 Narcans to keep on going. I mean, it's very, very potent if you don't even know it's on your clothes, so.
Pete.
Thank you. Pete Buttigieg from South Bend. This hits home a lot for us. We're in the industrial Midwest, and the issue's very close to home. I have so many questions, I can't really restrain myself. I'll get it down to 2. One, just quickly and specifically for Joyce. I was hoping you could explain the difference between an engagement center and some of the conversations around supervised injection. I know I didn't hear, if I heard you right, I think there's a distinction, but I'm just wondering, do you view a spectrum in terms of what, you know, can and should go on in a facility that's supervised or supported by the city? And then secondly, for whoever can answer it, a data question. So I went back to my team and said, let's start by just figuring out the scope of the problem, and found that it's harder than I realized to get a handle on how many of these deaths there actually are. I think largely for reasons related to stigma. Often it's reported as, let's say, cardiac arrest or any number of other things where these deaths are overdetermined. They tend to be linked to a few things at a time. I'm just wondering if you have any advice on how to get to the bottom of how many are actually overdose-related and how many of those are actually opioid-related?
Yeah, the engagement center is not a SIF. You can come in, you don't have to be sober to come in, but there are rules about behavior on site. As far as I know, there are no SIFs in the United States yet, right? Vancouver has one, but, yeah, I mean, I'm just going to say it, this is a room full of mayors, right? A SIF is going to be a very, very difficult thing to cite, to sell in any city. It's certainly something that we're keeping an eye on in terms of the good outcomes that Dr. Sharfstein mentioned that are happening in Europe, because it very definitely is happening. But yeah, the engagement center is not a supervised injection facility.
Maybe I'll comment on the data question, if that's okay. So it is absolutely right what you said, that a lot of medical examiners and coroners have challenges in general, in resources, in training and expertise, and figuring out overdose deaths. So however, there are specific protocols that you can ask them to follow, or you can try to get resources to help them follow, that talk specifically about the toxicology tests that can be done on the bodies, frankly, and then apply a set of rules to them. As an example, heroin gets metabolized in the body to morphine. And so sometimes you see morphine on the autopsy and you don't call it heroin, but really you should under certain circumstances. If they're needles, if it looks like heroin, it quacks like heroin, it's probably heroin. And we have looked at our data. It looks like probably death certificates are missing half of the overdoses. And that's even in a place where we have very, very strong medical examiners, and we apply a very specific protocol. So I think it's important to really understand how those deaths are being counted and why. A second thing that you really can think about is the non-fatal overdoses. Right, so your hospitals are seeing people who are overdosing, your EMS are seeing people who are overdosing. You can get that data, every day, and how you get that, different authority that you may have to get that reported to you, that can give you a sense of where the problem is, how the problem is growing. It also can increase the expectation that the responders are doing something about it. There was recently in Providence the head of Hasbro Toys, which is one of the big companies in Rhode Island, his son died of an overdose, and it turned out he had been in the emergency department like 7 times in the previous month for non-fatal overdoses. In public health, we think the biggest risk factor for something happening is something almost happening. Right? What's the biggest risk factor for someone dying of hypothermia, almost dying of hypothermia? Well, the biggest risk factor for an overdose is a death, is almost dying of an overdose. And so what are we doing when somebody actually almost dies? And so you can use getting that data as like a path to talk to the hospitals about, well, are you doing things like getting people into treatment quickly, and can we monitor that at the city level?
Thank you.
Thank you. Mayor Freeman Wilson. Please.
Good morning, Karen Freeman Wilson from the city of Gary, Indiana. I wanted to lift up a couple of things that I think really give us an opportunity as mayors to get involved. And I think Mayor Berry earlier talked about just this historical change in what the drug of the day is, and there has been over the decades a difference. But if we lead our communities in establishing an infrastructure that is around prevention, that is around treatment, both in and out of the justice system, that deals with recovery both short-term and long-term, then it provides an opportunity for us to just then switch in and out whatever the drug is. So then there can be specific treatment for cocaine or crack. There can be specific treatment for opioids and other related drugs. Sometimes it depends on the community. Alcohol is the drug of choice. So if we lead our communities in one, making an assessment, and then 2, creating this infrastructure, then we're better positioned to deal with whatever that drug of choice is. The second thing that I would raise is before we can, or I would suggest that it is important for us as public policy makers, as leaders, and other public policy makers to at least have a base level understanding of pharmacology. And I'm not saying that you need to go and take a course, but what I am saying is that we have the ability to convene just a 2-hour session for local leaders so that they will understand the pharmacology of addiction, because that really does go a long way towards removing the stigma that is often associated with this addiction. When you understand that, you know, it is not just someone waking up one day and saying, when I grow up, I want to be an addict, or I want to be addicted to alcohol or other drugs. It is something that changes in a person's brain. Then you begin to be able to explain it to others, and that you become a leader in changing the stigma in your community.
Mayor Freeman Wilson, I think you said it more eloquently than any of us, you know, and I think one mayor famously said, out of a great crisis comes a great opportunity, and we have a great opportunity here on addiction issues.
Thank you. Mayor Fisher, then Mayor Stodola.
Greg Fisher from Louisville. Can you comment on two issues? One is we operate the jail in our city, so we're the largest detox facility, and there is a lack of supply of treatment centers. I assume that's a problem for all of our cities. So are there ideas outside of traditional treatment centers where people are living and going through treatment? And we're in the process of building more, but this is an issue. And then second, Vivitrol and the effectiveness of Vivitrol, the pros and cons of that. Obviously, it's very expensive, but I haven't heard that discussed here yet today.
Those are great questions. And the first general thing to say is that detox is actually not the recommended treatment for people with opioid use disorders. Detox, what it does is people very rapidly come off their opioids, and they have often an intense craving, and their body readjusts. So when they go back to using, they have which they almost all do, well over 90% do, and then they can overdose and die. And so that's why you see tenfold increases in overdose rates, for example, in the first week out of jail, because people go back to using and then they die. And so in fact, some people say detox shouldn't even be part of the treatment system per se, because it's so much more effective to get people into therapy, but also treatment with medications like methadone and Suboxone instead of detox. A related point is that long-term residential treatment, which some people have in their mind as the gold standard, is actually not particularly effective and not the first line for opioid use disorder, because good programs of treatment with medications are so effective. That may seem counterintuitive. People think about how many beds do we have, but it's not beds that people need. It's a caring treatment program with access to effective treatment. And so what that means, there are certainly people who need inpatient detoxification, particularly for alcohol. But for opioids, it's really not the recommended treatment. And so what that means for a jail, for example, is even though everybody can be thinking of this as detox, somebody should say, what about starting treatment in jail? And there was a front-page New York Times story about how they're doing that in Providence and having just great results in the Rhode Island Detention Center. I once visited a detention center with, there were like two 75-year-old directors of the detention center. They'd put in a methadone program. They had been working in criminal justice for like 45 years, each of them. They could have had a cable TV show. They finished each other's sentences. And it was like, my jail is totally quiet now. We don't have any contraband problem with drugs, because all the patients, they get their medicine and they're doing great. And you know, they couldn't believe it. They were so happy. It requires a push, because some of the traditional thinking within the correction system can be resistant to that. Your second question was one, okay, if you get people started in treatment, what do they do when they leave? How do you link them? That's where really calling on your healthcare system to be part of the solution can be such an important challenge, thing for a mayor to do. Oftentimes, your hospitals, your physician groups, they don't want to have anything to do with addiction, and that has to do with the stigma. But if you can rally them to say, look, we're getting people started, we need a place for them to go. This is a medical illness, you've got to help us. You're seeing in different places, including in Rhode Island, the mayor, the governor is meeting with the big primary care groups and getting them to prescribe Suboxone, and they're investing in the right kind of services to support patients. So you can have a big impact for the detention center and then for the treatment center by calling on your resources that are there, including the big hospitals that oftentimes don't want to pay as much attention to this as they should.
A couple of comments, Mayor Fisher, too. The hardest part, and this is where mayor's leadership is helpful, is I think in the criminal justice system, especially with jails, this discussion on detox is a really big mindset change, just a huge mindset change to how they run the jail. So that's a really key issue for us, I think, particularly in the Midwest. Secondly, there's a money issue with it. So, and why this national emergency piece and what we need to call for on, a couple things. Number one, you know, you have a 16-person cap on Medicaid for treatment centers, and really if you're in a surge, we want those to be larger. I think Nevada's gotten larger. We've been trying to get that in Ohio, to have a larger amount of treatment facilities, so the national emergency will help if we push that. And then secondly, once they're out of jail, they can get Medicaid for those treatments, but when they're incarcerated, it's on the cost of the local community for those treatments. And so when you really kind of dig below the surface, that's what you're seeing. It's just that cost is so enormous to the local community that there might not be a want to do that because it's very expensive, and this gets back to cost again.
Yeah, and we're doing in-jail sign-up for Medicaid, so that transition takes place after that. Vivitrol,
Yes,
Doc?
I'm sorry, I forgot to mention that. Very briefly, Vivitrol is an effective FDA-approved medicine. Its mechanism is different than buprenorphine, Suboxone, or methadone. It's given by a shot. It lasts for 30 days. Some patients do quite well. Many patients don't want the second or third shot. So I think the general feeling is people should have access to all the effective medication-assisted treatments, and that it's sort of a clinical decision who's best for which of them. And the recent Opioid Commission, led by Chris Christie, made that as a big recommendation, that people shouldn't be forced to one medication or another. They should be given options. And oftentimes in the criminal justice system, people are only given the option of Vivitrol, and many people don't do very well on that. So it should be an option, but not the only one.
Thank you, Mayor Stodola, then Mayor Emanuel.
Mark Stodola, Little Rock. As we look at the number of first responders we have with police, fire, and emergency services, our ambulance, and we look at the expense of Narcan, I'm curious to know what other options there might be, or how that expense of, $37.50 per dose seems like a real strain, and will be a real strain on cities' budgets if we really try to have the ability to make sure that our first responders are equipped. So I'm wondering what can be done about that, if anything, number one, and number two, are there other alternatives out there that we can consider?
I can speak to that. You know, our product, when we launched, our mission was to have broad access to naloxone. And so at $37.50 a dose, it is, you know, affordable. There is the intravenous, the IV version that most first responders use, your ALS first responders, that you can, it's not a nasal, it's actually used through the IV, and it is less expensive.
Some of ours is reimbursed by the state, too, through CARAS, so there is opportunity there's grants there for the piece, too. You might check that with the state as well.
In Maryland, the Medicaid program made it available through Medicaid without any pre-authorization for basically anyone, and then allowed the city, and in Baltimore, for example, the city health commissioner wrote an order that anyone in the city can walk in and get it. So if they have Medicaid, they could get it covered by Medicaid. If they don't have Medicaid, their insurance could cover it, but there's an order from the health commissioner, and so insurance is a really important avenue to cover it for a lot of people.
Mayor Emanuel.
This is slightly more to my colleagues. In my last budget, I introduced a $1,500 fee for all pharmaceutical representatives who sell pharmaceutical products in the city, which pays for now treatment for heroin and opiates, and is a designated licensing fee just for pharma reps. You operate in the city of Chicago, et cetera, and we just did our first grant for treatment for 1,000 new patients, on the, particularly on the west side of the city of Chicago. Second, and I'll have my corporation counsel if anybody's interested, 4 years ago I sued Purdue. I'm in, obviously, discovery still with them. I know you find that shocking. And battling back and forth. But if you wanted to join that lawsuit, take a look at your own lawsuit. We have a lot of intellectual work. I'll say it, I don't really care. These guys are no better than the tobacco company when it comes to this product. And I say that as a person whose family is steeped in the medical profession. They have been, when you look at the amount of opiates that are prescribed in the United States versus any other country, we do not have more knee injuries and back pain problems. They are pushers. That is what they're doing. Third, I've explored, and I can't do this on a city level. I thought Governor McAuliffe or Terry's idea yesterday, you start making pharmaceutical or pharmacies give you the data of which doctors are prescribing. You don't want to know the patient, so you have privacy issues. You just want to know which doctors, the most, and you'll find out that there's a few doctors who are driving this drug market. We can, in all due respect, I mean, I know we have a crisis. I know we got to get a seat at the table nationally. I don't have a lot of high expectations for that. So our fee, all the pharmaceuticals fought me. In the end of the day, they're all participating. You sell it, you sell any pharmaceutical products as a sales rep in Chicago, you have to pay an additional fee, and now we have treatment money, which we did not have before. And then we have this suit from 4 years ago. If anybody's interested, let me know. We'll share you the data. If you want to do your own suit, you want to do it amicus. And lastly, I think we have to make the doctors come to the table. And if they don't come to the table, there's going to be a few, and this just can't be where the AMA points to the FDA and the pharmaceutical companies. All three of these players, in my view, FDA, pharma, and AMA, are participatory in finger pointing and not participatory in being held accountable. And they have a responsibility to come to the table, not just us come to the table. And they actually have to change their practice. That simple. And if we don't do that, we're going to be chasing our tail. There's no amount of money on some form of treatment.
Thank you, Mayor Emanuel. John?
Good afternoon, or good morning, everyone. John Mitchell, Mayor of New Bedford, Massachusetts. So I have a couple of questions for the panel. And they both fall into the category of what mayors should be demanding of two important players. Dr. Sharfstein, you mentioned earlier that some large multi-purpose hospitals aren't pulling their own weight. And in my city, our largest hospital, I think, could be fairly accused of that insofar as that it readily discharges folks who clearly have a problem. You know, we've seen time and time again instances where they have discharged folks who are frequent flyers, and these are people who, you know, will be right back in the emergency room with another overdose, and sometimes until it's their last one. So, first question is, what should we be demanding of them in terms of how we articulate our expectations of their effort to place people into treatment? And I know there are legal issues around civil commitment and so forth that can get a little thorny. So that's the first question. The second question is, you know, this meeting is, the purpose of this meeting, the primary purpose of this, why we're here this weekend is for the mayors to refine, our conference to refine its positions, its demands of the federal government on issues that are important to cities. And obviously, this is near the top of the list. So what should we be demanding of the federal government as we advance our policy agenda on issues related to the opiate crisis?
I'll comment on those. On the hospital side, I would draw your attention to the Rhode Island hospital standards that the health commissioner put out, and all the hospitals are now agreeing to meet. She set up, like you have for trauma centers, level 1, level 2, level 3 trauma centers, she set up very specific definitions of what she expects hospitals to do to be part of the solution, level 1, level 2, level 3. And we could, happy to make that available to the U.S. Conference of Mayors. It's online. She went through a year process to define the standards based on evidence. And what it looks like are things like recovery coaches who come into the emergency department and meet with people and help them get into treatment, the ability to start treatment in the emergency department, the ability to start treatment on the wards. Many hospitals, many hospitals do not do those things because they don't see addiction as part of their remit. And what she has said is this is like not treating diabetes that comes in. And so she set up very specific standards, and I think that would be a really strong starting place. In terms of the federal question, I would immediately, three things come to mind then. One would be money and being able to support the kinds of efforts that are being talked about here, particularly like in the detention center where you don't have funds for things. The second would be data. The federal government's ability to do surveillance on this challenge is terrible. They're often a year or two behind. They're using, and they should be setting up surveillance all over the country. It's taken way too long given the scale of this emergency. And the third is supporting different kinds of treatment expansion. And under an emergency declaration, the president could actually deploy people into your hospitals if they're not interested in starting treatment to get people to start treatment. There are things that the federal government could do to ramp up access to effective treatment very quickly, and I think that would be important. I just also wanted to say I think Mayor Emanuel is completely right about the fact that there are a few doctors who are causing a huge part of the problem. The research is catching up to that intuition, and research at our school is showing that while people are talking about changing prescribing for everyone and the dentist who gives 30 days instead of 3 days, that is important, but there are just literally kilograms of opioids being put out by certain practices. And the law enforcement model requires a lot of evidence gathering before those are shut down. It often takes a year or two to shut one of those down, and the amount of opioids they put out in a community are huge, and I think it is possible locally, if you're able to figure that out, to do things that could help shut them down faster. And you could get help from that from the federal government, the DEA, but also from the state. In Maryland, we had a special state DEA number, and we would pull that number and keep them from prescribing immediately. We wouldn't have to wait for a 3-year investigation, which maybe you want them to go to jail, but you don't want the 3 years of all those opioids on the street.
Yeah, I think he's right. The other thing is we want to make sure that right now there's no local conversation at all around the national emergency, so we want to make sure that we're there. And frankly, the cost on, again, fire and EMS, is detailed and shown, just like when you have a natural disaster through an emergency that is detailed. We can see that in our communities on how that cost is affected, and being able to deploy those resources right now to stem what is an enormous surge through fentanyl and carfentanil.
Mayor Cooper, and then Mayor Doyle.
Yes, good morning. Mayor Cooper from the city of Hallandale Beach. First of all, I want to commend Mayor Whaley for her efforts in the lawsuit and her leadership on this issue. Thank you for that. Mayor Emanuel, my husband is an orthopedic surgeon, so I get this issue as well. I'm having flashbacks about 10 years ago, sitting around a table just like this, having a meeting with the national government, DEA, and Big Pharma, and actually asked the question, why are you pushing this drug, and why are you pushing this drug so hard? In my husband's practice, he maybe had prescribed at that point maybe 3 prescriptions for people that had the necessary back problems or issues the chronic pain issues that necessitated possibly this prescription. So there's a lot of bad players in this whole concept. So going back to your model, I would suggest that, you know, we have a problem with states. We fought for years to get a drug registry in Florida. And it's just common sense at this point that, and my husband last night at dinner said, whoa, you know, there's some people that need this drug. So I don't want to be handcuffed as an orthopedic surgeon. So one of the questions is, you know, a dentist needs to prescribe OxyContin or some of these drugs for some temporary pain. I think that model really needs to be looked at. Doctors need to be at that table and what the prescription model is going to be for these types of drugs moving forward. But I think the federal government and Big Pharma is really, really the big, they saw this coming and actually kind of said, well, you know, we're going to feed it. And Big Pharma should be paying for this one way or other. Again, congratulations, Mayor, on your efforts to sue them.
Mayor Doyle, then Mayor Soglin.
Thank you. Danny Doyle from Beaverton, Oregon. Just a speculative question for the panel. The recently concluded national group under the President's direction came up with some suggestions, results, and proposals. Do you think any of that is going to help us in the long run?
If they do it, I mean, I think that those recommendations, I mean, a lot of them are things that we've said. I think the question now is, you know, will it really move quickly to the communities, and will anything actually happen? I think that's our big question.
Thank you. Mayor Soglin.
I'd agree.
Thank you. I've got two unrelated questions. The first is, when the identification is made regarding the map we first saw, is it based on the individual's residence, or is it based on where they've overdosed? And then the second question is related to income. Now, we know that the addiction crosses all boundaries, and wealth is not going to be a barrier to addiction. But in our own work, we're finding that there's a disproportionate number of low-income people, underemployed people who were related to the overdoses we have. My question is, the stress, the economic stress that so many households are encountering now, is there any evidence that that is related to the addiction?
Go ahead, Doctor.
Well, I would say absolutely yes. The economic challenges, economically distressed cities have generally speaking, a much greater challenge here. And I think, you know, Dreamland is a great book to read to get an appreciation of how that actually plays out in practice. I was recently speaking at Bloomberg Cities event, and the panel that I was on really talked to cities from, it was much more about the prevention side. So many things that mayors work on and that you work on for the economic vitality of your city, for the strength of your school system, all those different things, those are a long-term form of prevention. And in general, the city's agenda is a prevention agenda for opioids, because you have vital cities really give people other opportunities besides drugs. As one example, there's very good evidence that kids have trouble in school before they turn to addiction, before they get in trouble with drugs. It's not the reverse. Occasionally you'll see someone who's doing great in school and they, you know, someone gives them something and they get into trouble. The vast majority of times they're really failing in school first. And then, you know, they feel bad about themselves and they drop out, and then they wind up in that world of all kinds of hazards of adolescence, including addiction. And so the school system, the economic opportunities, community development are very important, and investing in those is very important for the long term. We've been talking a lot about short-term solutions, but that really is the long term. The other thing I would really recommend reading besides Dreamland is an online Pulitzer Prize nominated set of articles called Dying to Be Free. Dying to Be Free, and it really talks about treatment and what works and what doesn't, and how our ideology and stigma sometimes can get in the way of effective treatment. It was a really great series, so Dreamland and Dying to Be Free are really great.
And Doctor, the map that he said from 99 to 2000,
Oh yes,
where
it's
they
based on
died.
residents. It's going to be based on residents. Most death reporting is going to be based on residents. Sometimes you can get someone to look at it differently, but the traditional way is based on residents.
Our CEO, Tom Cochran.
We have been talking about drugs in this country for a real long time. And just some observations. I have to always ask the question, when we had the Zika virus, I have to always ask the question, is where's the Surgeon General? And do we still have one? Mayor Morrell also, who is the head of the National Urban League, has made the comment that opioids is basically a white person's disease. As we talk about the drugs, let's not forget the other community that has been suffering from drugs for a real long time. Last night, the governor from Virginia said, in my state, you can draw a line through it. On the east side, it's still meth. It's still that community. You know, on the west side, which borders Appalachia, West Virginia, et cetera, it's opioids. What's happening at the national level? What's happening at the national level? The president really dealt with this in the campaign. A national commission was announced several months ago. We go to the Big Seven meetings. I asked the governors, Governor Christie is in charge of it, and I asked the Governors Association, we need to be discussing this. It was there with the county officials. And they said, you know, this is just a joke. It's not the real thing. I said, well, you know, a commission has been appointed. Commission was appointed with 5 national cabinet officers, people in the government, with outside members, which I think total 4 governors, and 1 individual congressman, former Congressman Kennedy, Pat Kennedy. Yes, on Tuesday, the president had a press conference. It was expected, where he's vacationing, that he would announce a national epidemic. He refused to do so, saying that we have to teach our young people, et cetera. The HHS Secretary, Health and Human Services Secretary said, wait a minute, Kellyanne Conway spoke on the issue along with the HHS Secretary and said the president will not announce it, but then he said everything is on the table. 24 hours ago, the president has said there's a national epidemic. There are no local officials or county officials, local officials, city county officials, or health officers on the commission. Yesterday afternoon, we met with the top 3 officers of the National League of Cities, 2 of them in this room, and also with the top 3 officers who came to this meeting from NACO. And you know, we have all agreed that we need to request the commission to at least testify or give our views. The mayor of Chicago is recommending some very strong measures, and we appreciate what he is doing in his city and what all of you are doing. But in order to, and you heard what Dr. Sachs said last night about the pharmaceutical company. This is a very powerful lobby. If you look at, I think they're #1 along with Northrop Industries as far as lobbying. So it's going to take, and let me just to throw this out for what it's worth. 1981, we had a man named C. Everett Koop who came to our meeting and says, mayors have got to get involved in the AIDS epidemic. You got to use the word condom on TV. You've got to use the word semen on TV. You've got to get involved. We worked with C. Everett Koop. In the Reagan administration, we had a lot to do with the AIDS epidemic. So we do need to focus as we are gathered here as a national group. This organization has not really spoken. The League of Cities has done an incredible report on this. They had it yesterday. So we are very powerful, and I think we need to, at some point, Mr. President, think about what we are asking of the federal government, recognizing that we can't wait for the federal government. But it really grieves me to see what's happening in our nation and not having the federal government more focused and more hands-on. In Miami a year or a half ago, Mayor Fisher, you remember, we were talking about the Zika virus. It was spraying the hell out of everything near water all over the nation. So I think we need to, at some point, maybe tomorrow, if not, we're having a press conference today, decide exactly what our position is with the federal government, with all due respect to the fact we do appreciate that yesterday the president did declare this to be a national emergency.
Mayor Barnett, Mayor Couts, and then we're gonna try to put a bow on this, get on schedule.
Thank you, Mayor Benjamin. Really fantastic discussion today, and I want to thank, as many mayors have, Mayor Whaley for your national leadership on this. You know, listening around the table, a lot of really good discussion and direction, and I always want to bring it back to something practical that I can do, and maybe, as Mayor Emanuel mentioned, some of the things he's doing in Chicago, some of the things that we did in Rochester Hills that didn't cost anything, didn't need any approvals, and something you could do on the way home. First of all, was understanding the problem, and in my community, nobody was talking about it. It was a Kentucky, West Virginia issue until we started understanding the numbers, and maybe my raw data isn't as great as some of your larger communities, but the increase of opioid deaths in my city was 116% year over year. And in Michigan, we found out there were 11 million prescriptions written last year in a state with a population of 10 million, and those numbers made sense to people when you started to talk about them. And we intertwined that with the story of the gentleman that we saved twice at the Target parking lot on Friday and twice the following Saturday in his neighborhood. And we started to have this conversation. And if you have not, as a mayor, written an op-ed about this, you should. It's simple. They'll run it. You know they will. It's nonpartisan. There's no one that will fire back. It's just beginning the community conversation, and it's something that no one was talking about it in my community in any sort of positive way. And connecting healthcare, the healthcare folks with the first responders, with just getting information. Still in many of your communities, this may still be sort of a taboo discussion, and it certainly was in my community, and we just started talking about it. I think Joyce from Boston mentioned using purposeful language and dealing with it head on was something that we recognized. Now, I hope that everyone in my community knows that opioid deaths are on a dramatic increase. I hope they know how many prescriptions are written in the state of Michigan. I hope they know where they can start to find help. Those are things, as mayors, as the great connectors of our community, it's incumbent upon us, I think, to have those conversations. And again, those things are simple. You know, if you choose to join a lawsuit, that's fantastic. But this is something that you can do, maybe even while you're sitting here, have a staff member put together something that, in terms of an op-ed that talks about what's happening in your particular community. And we have led that discussion and seen great results from it.
Thank you, Mayor Barnett. Mayor Couts.
Thank you, Vice President Benjamin. And I want to thank Mayor Landrieu, our president, for his leadership on this, but most importantly, to the folks on our panel and Mayor Whaley, and also Mayor Cooper, thank you for putting forth your husband's experience as a physician, because as we look at all of these issues, there's a huge stakeholder people who can work with us to help solve this. And the solutions and the strategies that Mayor Emanuel is exercising in Chicago, we can all learn from all of the best practices. I know that in my city of Burnsville, Minnesota, our police department, our police chief, continues to work with our pharmacies because just recently, and I'm sure all of you experience this, there are robberies and they're all opioids with Walgreens, CVS, and other pharmacists in our city. So it is going to take all of us to work together, all of the different constituencies and impacted disciplines within our community, the hospital. One of the things that I do is to work very closely with the president of our hospital and also the Physicians Association. There is a Association of Hospital Administrators. I think if all of us come together, there are many things that we can solve together, not only the opioid challenge, but also the healthcare challenge. We need to bring all of the different stakeholders into the mix. We are the great conveners, and we can do this. So with all of the information we have learned today, I have been sharing with all of my Facebook friends and all of the people in Burnsville to tune in to USCM Facebook, and they're tuning in. Matter of fact, my family from Copenhagen is also joined into this discussion. So I think we can certainly get a lot of good information on how we can all continue to work together. But thank you to everyone who has brought their experience to this conversation, because that's how we can solve the problem.
Thank you, Past President Couch. We're going to wrap up this session. I'm going to ask all the mayors and staff to stay in this room for a quick briefing while the media moves to the press conference room, where we'll all depart to after we have our quick briefing. Thanks again to our incredible panel, incredibly helpful information. The toolkit that's been produced through the conference with Mayor Walsh's leadership is incredibly useful. Mayor Whaley, I want to thank you for your continued leadership, and I want to thank all of our colleagues for the incredible advice and counsel that you provide for us today. We got to make sure we put this all together along with these incredible presentations, which I assume are going to be made available to all the mayors as well. This is great data that we all need to take home. So let's make sure we bottle all this up, and we'll have a chance to talk about it a little bit at the press conference. So mayors and staff, stay in the room. Media, slide on out, and we'll pick up in just a few minutes. Thank you.